Hello, everyone, and nice to meet you again. We will talk today about the introduction to the endocrine therapy for early breast cancer. These are my financial disclosures. The story of breast cancer starts in ancient years ago, where we have ancient Egyptian papyrus and ancient Greek uh, prescriptions where there was described the symptoms, the signs, and possible treatments of this very hard to treat disease. That have been the story till Sir William Halsted published his first work on the first described radical treatment for breast cancer, the so-called radical mastectomy, which is a surgery where he did remove the whole breast and removed the axillary lymph node. More than 100 years ago, this was the radical treatment. However, he also noticed that many of his patients, where they successfully had their radical treatment, they suffered relapse, metastasis, or local recurrence that's related to the cancer cells remaining even after this radical treatment. A very interesting and dramatic story continues, where almost in the same period of Dr. Halsted, another physician, Dr. Beatson, have noticed that some patients showed spontaneous cancer regression after cessation of the menstruation around the age of 50. And this have made him start his first endocrine therapy for breast cancer, where he did ovariectomy for only 3 patients with advanced or metastatic breast cancer. In this first cohort, which he did publish in the Lancet journal, he noticed regression in the cancer in all the 3 patients, with one of them having complete remission, meaning that the cancer disappeared after only removal of the ovaries. This is a very solid proof that hormones have something to relate to breast cancer. Then we are now in the 50s and the 60s, more than 60 years after Dr. Halsted and Dr. Beatson started their approach to early and metastatic breast cancer. However, the problem of cancer metastasis and recurrence is still there. And another very intelligent physician have suggested that in patients who had already their menopause, where the ovaries are no more the source of hormones, but another gland that is the adrenal gland might have a thing to contribute with the sex hormones. He did adrenalectomy as a therapeutic option for curing advanced breast cancer, and he have observed some sort of success. So after all those very smart clinical observations, yet we have a very strong scientific biological rationale behind the involvement of estrogen in the growth of breast cancer. First, estrogen is an important growth factor for both normal and malignant cells, actually. Estrogen is involved in maturity of the breast, the ovarian, the uterine tissue, and this happens because estrogen, in addition to the estrogen receptors, which is in the green here inside the nucleus, both form a complex. And this estrogen receptor complex could recruit another co-activators within the nucleus, and this binds to the DNA, specific parts of the DNA called the estrogen response elements. This complex initiates a process called transcription, which is the synthesis of messenger RNA, the molecule responsible for telling the cell that we should have an action through proteins. And proteins happen by the so-called translation. Those proteins are responsible for many of the functions involved in normal growth and proliferation, and in addition, the cancer growth and proliferation. So, what does estrogen do for the normal cells? That's very important to know because estrogen is an essential for many physiological functions other than the commonly known sexual characters. Estrogen is responsible for the brain. So, other than libido, memory and mental health are very closely dependent on estrogen levels, and hence some changes can occur during after menopause. Also, muscles and bones are affected clearly by the estrogen presence. So, during the premenopausal period, the estrogen levels are high, the bone microenvironment are more healthy, and hence the incidence of bone loss is very low. But after the menopause, you have what's called bone thinning or osteopenia and osteoporosis. In addition, the breast development, of course, is dependent on estrogen. And of course, here we know that some breast cancers are also dependent on estrogen. A very important function of estrogen is excreting the lipids in the bile. And this will decrease the risk for atherosclerosis markedly in premenopausal women compared to men. In the postmenopausal women, the incidence increases for the heart disease increases gradually till it approaches the risk of atherosclerosis in men. So, where does estrogen come from? That's a very important to know. First, it starts with a signal from the hypothalamus, secreting what's so-called GnRH, which is the LHRH, the luteinizing hormone releasing hormone, or the FSH releasing hormone. So, with those secreted, they stimulate the anterior pituitary. And again, we should know that the GnRH endocrine secretion is through a pulsatile secretion. So it's not steady presence. With the pulse of GnRH, the pituitary then know that she have to increase the secretion of FSH or LH, which is a messenger from the pituitary to the ovary. Here in the ovary, we have the granulosa cells and the theca cells. Those are responsible for the secretion of estrogen through different chemical transformation, starting from cholesterol, passing by the androgens, then ending to estrogen through an important enzyme called the aromatase enzyme. So this is how the pulsatile GnRH secretions in the hypothalamus result in the estrogen secretion from the ovary. And here we can see the menstrual cycle on the level of hormones and on the level of ovulation. So here is the area, the region about around the ovulation, around day 14 in the menstrual cycle, where it's initiated by the pulsatile secretion of LH and FSH, which increases the progesterone throughout the second half of the menstrual cycle and signals the ovulation, which might or might not cause conception and pregnancy. After we knew where does estrogen come from, we should know where does it go after menopause. Around the time of menopause, and let's say age 55 for example, the estrogen and progesterone levels start to go down. And the FSH and LH goes up, trying to push the ovary to secrete as much as it can of estrogen and progesterone. The ovary tries and tries to produce more hormones. It gets exhausted, even with the sky-high levels of FSH and LH produced from the pituitary. Finally, on the long run, it fails and the estrogen and progesterone levels drop to the so-called menopausal levels. Till this point, the story of menopausal levels of hormones appears simple. Menopause means high FSH and LH with low estrogen. However, let's look into the bigger picture. Years into menopause, even the pituitary gets exhausted and stops in despair to secrete that high levels of FSH and LH. That's why we can find in these women with deeper and prolonged menopause, all the hormones might be low. Back to our fight with breast cancer and back to history again. Two smart scientists have invented an anti-estrogen medication called tamoxifen. It was intended to be a morning after pill contraception method. Yet it was a complete failure. and women kept getting pregnant after taking it. This was a major devastation for the brilliant scientists. But this great failure was about to be the one of the best news that breast cancer patients were here in the history of this very long fight. Two studies conducted in the United Kingdom, one in the Christie Hospital in Manchester and the other in Queen Elizabeth Hospital in Birmingham, have found a very important observation. And throughout the 70s, several other studies noticed the same. Tamoxifen provides significant improvement in the responses in patients with advanced or metastatic breast cancers. More than 80 years after Dr. Beatson's ovarectomy, finally, we have an endocrine medication that can be used to treat advanced breast cancer. Let's see how does tamoxifen treat breast cancer. Tamoxifen is a competitive estrogen analog. That's a drug similar in structure to estrogen and bind to the estrogen in high affinity. This means that even in the presence of high level of estrogen, it might not be able to reach the receptors and to do the previously mentioned actions on the DNA. And let's remember that the complex made of estrogen, estrogen receptor, and the coactivators are all needed for the growth and proliferation of cancer. But what happened to this complex of tamoxifen binding to the receptor? For the good luck of breast cancer patients, this new complex is unable to recruit the coactivators, meaning that in the presence of tamoxifen, the ability of cancer cell to grow and proliferate is much lower. So, if it works with cancer that already exists, like metastatic disease, can tamoxifen be used after surgery to decrease the cancer's ability to spread and to recur again? Randomized studies were done to test the value of adjuvant tamoxifen after successful surgery. Early studies testing giving tamoxifen for 2 years compared to no treatment, and tamoxifen could improve the disease-free survival and overall survival. Furthermore, a large meta-analysis of randomized trials called the Early Breast Cancer Trialists Collaborative Group, or the Oxford meta-analysis, that included more than 10,000 patients with breast cancer following surgery. It compared adjuvant tamoxifen versus no adjuvant treatment. And the results was very clear. Tamoxifen decreases the recurrences, by 40% and decreases the mortality rate of breast cancer by 30%. Finally, when we compare the duration of 2 years of treatment versus 5 years of treatment, the 5 years duration have proven to be superior, making 5 years of adjuvant tamoxifen after surgery for breast cancer the gold standard of treatment for at least 2 decades. This significant improvement came with a price of side effects. Tamoxifen, as expected, caused menopausal symptoms. That's because of its anti-estrogen actions, causing hot flushes, vaginal dryness, mood changes, and others. Among them are anxiety, depression. In addition, where it's similar to estrogen, it causes thromboembolism. Also, it causes proliferation of the endometrial lining, which will cause endometrial hyperplasia and, in a very rare situation, can cause endometrial cancer. In addition, due to its effect on the fat distribution, it might cause, in some patients, weight gain. However, the interesting thing about the tamoxifen effect and side effects are that it have a mix of an agonist and antagonist action compared to estrogen. So, in some tissues, tamoxifen can act very similar to estrogen and cause estrogen-like actions, while on other tissues, tamoxifen can have an anti-estrogen actions and hence explaining its effect and side effects pattern. So, for example, on the brain, on the breasts. It have an anti-estrogen action, causing something like the menopausal vasomotor and psychological symptoms, and causing, of course, atrophy in the breast and, for our luck, reduction in the growth of breast cancer. On the other hand, on the other tissues like the bone, the muscles, the fat distribution, and the uterus, it causes side effects or effects that's very similar to the estrogen. So, while we're giving tamoxifen to our patients or any other hormonal treatments, we must think of how to manage menopausal symptoms. So, the first to think of when we treat menopausal symptoms are, can we use hormone replacement? This have been the best described medication to treat menopause. However, it's risky in breast cancer patients. A study called the HABITS trial reported a threefold increase in the risk of appearance of another cancer or recurrence if we used hormone replacement therapy in patients with hormone receptor positive breast cancer. However, local vaginal hormonal therapy might help in relieving the symptoms of vaginal dryness and improve the sexual life of the patient. We try to prescribe a non-hormonal vaginal lubricants, but in case of severe symptoms, using low-dose vaginal hormonal lubricants can help in the improvement with expected minimal risk in terms of cancer recurrence. Other non-hormonal approaches to treat menopausal symptoms are very important. Those are the examples of those approaches are maintaining a healthy body mass index, that's weight reduction, stopping smoking, limiting alcohol intake, and regular exercise. In addition to reducing the hot flushes or the menopausal symptoms, it also decreases the risk of osteoporosis, it decreases the musculoskeletal symptoms, and it reduces the risk of breast cancer recurrence or the appearance of other breast cancer. In addition, such lifestyle modifications are very important in reducing other healthcare problems like diabetes, hypertension, and heart diseases that might be associated with the same patient. Finally, non-hormonal medications can help. First, the SSRIs or the SNRIs used to treat depression, despite having no solid, large randomized studies to test against the hot flushes. However, they might reduce the severity and the frequency of symptoms. They can cause a pattern of other side effects, but they can be used in patients with severe vasomotor symptoms or severe hot flushes. In addition, other medications like gabapentin and clonidine also, despite lacking large randomized studies, these can help in reduce the severity of the menopausal symptoms and the frequency of hot flushes in breast cancer patients. These are who are under hormonal treatment. One final question. If using 5 years of adjuvant treatment after surgery improves the outcome, why not to give more tamoxifen? Why not to give adjuvant treatment for 10 years? Two large studies have tested this question. The first of them is the Atlas trial, published around 10 years ago, compared continuing for a total of 10 years of adjuvant tamoxifen versus stopping at only 5 years in patients who have done successful surgery and completed the first 5 years of tamoxifen. It's not that 10% of those were still premenopausal, and this analysis included only estrogen receptor positive patients. Please note that the value of adjuvant tamoxifen after surgery have been proven even after the discovery and the widespread testing for estrogen receptors by immunohistochemistry. This means that in the older study, patients with estrogen receptor negative disease used to receive tamoxifen, but now we know that the value is restricted only to estrogen receptor positive disease. The Atlas study results showed a significant but mild reduction in the risk of recurrence with extending the duration of tamoxifen. At least 4% absolute gain in the risk of recurrence at 15 years and 3% reduction in the risk of dying from breast cancer. This means that if you continue 5 more years of adjuvant tamoxifen, you benefit around 4 out of every 100 patients who receive this treatment. With this minimal gain of survival, we must look into the side effects of extending the tamoxifen duration. First, despite the decrease in the contralateral breast cancer incidence with the extension of the tamoxifen duration, however, endometrial cancer, which is precipitated by tamoxifen, have increased significantly in those patients who received 10 years compared to those who received 5 years. In addition, pulmonary embolism and ischemic heart diseases have showed significant increase with the extended duration of tamoxifen. A second study tested the same question is the ATOM study, which compared similarly patients who received 5 years of tamoxifen to either to stop tamoxifen or to continue for an additional of 5 years. And if we look at the combined analysis of both the ATLAS and the ATOM study results, you will see a disease-free survival improvement with the extended duration around 25%, but this improvement appears only after year 10 of treatment and is not visible during the second 5 years of tamoxifen. Similarly, we're having 16% reduction in the risk of dying from breast cancer, but this reduction appears after 10 years of treatment and not during receiving the second 5 years. Finally, regarding the duration of adjuvant tamoxifen, we must weigh the advantage versus disadvantage of this approach. Compared to 5 years, you have an improvement of disease-free survival with a relative gain of 15 to 25% and an improvement of overall survival, that's reduction of dying from breast cancer, around 15%. It's a cheap option. Tamoxifen is a cheap medication that's widely available worldwide, and it's suitable for both pre and postmenopausal women. However, it carries some safety concerns, specifically with the thromboembolism and with the increase in the risk of endometrial cancer. In addition, the gain of this strategy is relatively low when you compare to another newer medication, for example, like aromatase inhibitors. Finally, I'd like to thank you very much for watching, and you can check other videos on the same channel, and you can subscribe to the channel if you want to receive a notification if any other videos are posted.